I think the other thing that you guys need to do in the pre-hospital phase and figure out is the temperature management of patients. And making sure the patients, when they come to us, they're toasty, 37 degrees. Because for clotting to happen, we need a warm patient. And so we need a patient coming to us really warm. And we have some cold months of the year. And so I think we need a lot more research on what's the best blankets. You know what I mean?
And you mentioned it's effective, especially effective in the first hour. Our medical directives at this time that anyone that's had an injury greater than 3 hours, you don't give it for.
Yeah.
How come that's in there?
Yeah. So in the CRASH 2 trial, they allowed patients to be enrolled in the trial and get it out to the 8-hour mark. And then afterwards, they did a subgroup analysis of people who were started within the first 3 hours versus started between 3 and 8 hours. The patients that were started between 3 and 8 hours had no benefit in terms of mortality. They didn't have a higher mortality rate. But what was really weird is they were more likely to bleed to death. So it was changing how they died rather than changing the body count. Your trauma-induced coagulopathy pathophysiology is changing every hour throughout the resuscitation. And so we know that things are changing. And so probably other stuff's happening in that beyond 3-hour mark that possibly make TXA not a good thing to give. So definitely after 3 hours, there's just no benefit. So don't bother. That would be pretty unusual that somebody, was injured more than 3 hours before you got there. That must be an unusual situation. Like from our trauma trials, the transport times are running around 30 to 40 minutes.
I'm just thinking anecdotally, like it is a very seldom occurrence. I think of one patient where we found them in the ditch and nobody saw them all night. So that was always the example we taught in the education. It's like, if you can't establish a timeline, you find them next to the ditch. It's like, how long have they been here? But otherwise, most people are like car accidents or any other type of accident, you're going to have witnesses and probably call pretty promptly.
Yeah. You got the 911 call time. So you kind of know within a few minutes of when the trauma actually happened.
Has Orange been doing TXA for a long time?
Yeah. I can't remember how long, but definitely a long time. I don't know, 5 years, more.
And they're giving 2 grams now too, right?
Yeah.
I'm just thinking, especially for our more rural services where you have to call for Orange and then they take them to the trauma center, that's good to have that communication handover too, that I gave 1 gram, so they would potentially follow up with another gram and not 2 grams.
Remember though, if you forget to tell somebody, the STAMP trial had an arm where patients were getting 3 grams. So we know it's not harmful to give 3 grams. Possible it might be better, but the study wasn't powered to look at that, difference. But if the patient gets 3 grams because the handover, you just forget, I'm okay with that.
Interesting. And again, no safety flags, still very effective.
Yeah. I think what we don't want is them only to get 1 gram. I think we need to get the 2nd gram into them. So I think it's really important that when you do say, I gave TXA, but remember we're EMS, we just give 1 gram. You have to give the 2nd gram.
I'm thinking that we should do more education when patient handover for the I missed ambo and making sure like TXA is clear with the dose. And I was watching one of your talks and you said at the beginning too, that sending a mass emails to everyone that this is TXA, this is the protocol, had kind of low
penetration. Nothing. Yeah.
So yeah, we had to look at it from a system lens. So that's an interesting perspective.
Somebody's going to have to come up with a slogan. When we tried, we used to give, 2 red cells at the same time. And then we had to undo it. So we came up with a slogan, why give two when one will do? So one of your medics has to come up with a slogan, you know what I mean? I don't know. There's got to be some good, I don't know, put it into Chat GPT to get some sort of slogan about the second dose. Yeah.
A little witty slogan from ChatGPT. We can do it. We'll try it. And you already mentioned this one because currently the medical directives are going to align with the drug monograph, I believe, to infuse TXA over 5 minutes because the black box warning says it may cause transient hypotension. But our medical directors were like, I don't think that evidence is well substantiated. So again, there is no evidence to say that it will lead to hypotension.
Yeah, and as I said, the ROC TXA trial, one of the arms was 2 grams, wide open.
How come that black box warning is there?
There's lots of black box warnings on a lot of different drugs, right? Like, it's a lot of work for these pharmaceutical companies to go back and change the labeling on the products. So you're not going to go back and change it unless you absolutely have to, because those labeling changes cost massive amounts of money. Yeah. There's some crazy black box warning on vitamin K. We give a lot of vitamin K to people that are bleeding because they're, vitamin K deficient or whatever. And it has a warning, don't give it intravenously. And I'm like, you have to give it intravenously. So, when we give talks, we're like, this is a secret you need to know. There's a black box warning. It's not real. Ignore it. And you must give it intravenously, even though the black box warning says to give it, some other route.
That makes sense. Money and takes a lot of resources to change all that. Good to know. What about storage and temperature? Does that matter how ambulance services store and maintain the TXA in the ambulances?
So definitely we want you guys, obviously making sure that you're not giving expired TXA. Like the thing has an outdate on it. So definitely we want to make sure that whoever's checking the ambulances is checking the vials. And obviously when you go to give it, if it turns out there are some times of the year where we don't have that many traumas in our country, February with the driest month. When I was at Sunnybrook, we would go days and days without a trauma. So there might be times where, you really should be watching the outdate on your TXA versus in the summer, you're going to be going through it like hotcakes, right? So you're not going to worry so much about that. And then following the package inserts have very specific temperature ranges for every single drug. And so just making sure you're within that range. And if you deviate, you can still deviate from the package insert, but you've got to just validate that worked. And so that's what the UK did, where they validated that a syringe of TXA remained stable and didn't become bacterially infected. And so they had 24 hours so they could pre-draw it. So to reduce the cognitive load when you're managing the trauma, you just have to grab the syringe and push. I guess you could also push it into your IV bag. If you're giving fluid anyways, run it in with the fluid if that's less work. You know what I mean? I think it's really important that we figure out what is the path of least resistance that makes it cognitively the easiest thing to do.
Because we get task saturated, especially in high acuity traumas. And I'm just trying to anticipate that this is a new drug, new medication, and how we can prevent paramedics forgetting it. Because again, it's so important to administer. And if we pivot, if we look at our medical directive at this time is for trauma and TXA. But does TXA have any other benefits in any other patient populations?
Yeah. So we know so the GI bleeding, I don't think there's any GI bleeding situation where you would give pre-hospital TXA. So GI bleeding is out. If you guys are managing, I guess it's possible that you're managing a postpartum hemorrhage. Somebody starts delivering really, really quickly at home, or they had planned a home birth and it goes sideways. We know that it's reduces your chance of a hemorrhagic related death if you give it for postpartum hemorrhage. We do routinely give it for some less severe bleeding. Like we'll often give TXA in packing for the nose if someone has a nosebleed, or we'll give it in the packing. Someone's got like, I don't know, a dental massive tooth bleed from a dental procedure. We'll put the TXA in the gauze and get somebody to clamp down on it and to push the TXA into the wound bed. So we use TXA pretty liberally in other situations. We actually give TXA routinely for any major surgery where there's a chance of a bleed or a transfusion. So it's routine if you're having a hip replacement, you had a hip fracture, and you're having, your hip pinned, knee replacement, like a major cancer surgery. All those patients get TXA 1 gram when they enter the operating room and 1 gram when they're finished in the operating room, and it's like a sandwich. So this 1 gram infusion is happening every minute in this country. You're just joining us when we're 20 years into this journey. So, yeah. So we're really chill about TXA, and obviously it's new for you guys, but honestly, I think by the end of trauma season, when, Thanksgiving weekend comes along and the trauma season is kind of over, you've had the whole trauma season to get used to giving TXA, and then I think it's just going to become just rote. Do you guys, when you're going out to like a trauma, are you always like, okay, we're picking up, like it's a gunshot wound, we're going? Are you going to your head with, okay, what am I going to do first? What am I going to do second? Just so that like TXA is in that mental prep as you're heading to a patient.
I can't speak for everyone. I tried to do that, and just talking to individuals like you and other high performers, they always say that, like, have a checklist. These are the expectations. This is what I'll do if this happens, and this is what I'll do if it doesn't happen. So we should consider it. We will try to monitor the compliance, like just from a patient safety lens to make sure patients are meeting the standard, but there will be some humps. But I'm glad we have some time to get out this education to keep reminding people. And I love that you said that TXA is given every minute in this country, and there's no signals that it's harmful. There's a lot of signals that it's beneficial in numerous pathologies. And like the GI bleed, like esophageal varices.
Yeah.
Wouldn't work?
Well, won't work. And it increases. Well, the dose they gave in the trial was called Halt It. And the dose that they gave was a total of 4 grams. And it didn't change any of the bleeding outcomes. And it increased marginally the thromboembolic complications in that population whose coagulation is so deranged. Like, you think of a liver disease patient and their clotting times are super high, but actually that measurement doesn't include the measure of the fact that their natural anticoagulants that are preventing them from having a clot are super low. So even though their INR is 3, because they've got really bad liver disease, they're actually hypercoagulable. And so I think a lot of people don't think, because, they're having a variceal bleed, they think they're coagulopathic, these liver disease patients, but actually when you go deeper into the coagulation testing, they're hypercoagulable. And so it's probably not good for them.
And that goes back to what you said at the beginning, that some of the subsets of the population that TXA you got to be careful on is liver patients. For that reason, that's such an interesting, nuanced perspective.
And I think that's really common in Canada. I came from an area of, Toronto that didn't have a lot of, alcoholism and problems with drinking. And then I moved to Kingston, and then I realized, wow, our country has a drinking problem. Like, there's a lot of people with cirrhosis. There's a lot of people with GI bleeds. It's a really common thing that we see down here in southeastern Ontario. So I think it's probably really common for some of your medics to be seeing cirrhotic patients that are bleeding. I think that's pretty common, particularly in the, outside of maybe the GTA.
It's funny how just even 2 hours one way could change the whole patient demographics and illnesses that you see.
Yeah, completely. One of the things maybe we need to do is making sure the emerge docs, when they're receiving the patient and your team says, hey, I gave the first gram, they're like, hey, well done. Do you know what I mean? Some really good positive feedback coming from the emerge docs. Hey, good. Or the emerge nurse says, hey, well done. Thanks so much for doing that, because it makes our job easier. I think also making sure that there's communication out across Ontario. Hey, this is starting. So just some situational awareness that your patient's going to be coming. Hey, if you have protocols where you've already pre-drawn up 2 grams of TXA, you're going to have to change your protocols so that you're just giving 1 gram.
Having everyone connected to optimize patient safety and getting it in.
We're all on one team. Like, it feels like we're all kind of segregated, but honestly, we're all on the same team.
What about the women trial? Can you speak to the rigor of that trial? Because I told you this, that there's some opinions that the quality of evidence in that trial is low for TXA.
I'd say that the quality of the trial is low. I would say that the benefit for postpartum hemorrhage is less than it is in trauma. In trauma, it's like clearly a lifesaver in terms of saving lives, versus because so few women die in childbirth, it's really hard to show a mortality benefit because the risk is very low. In addition, it must have been really hard to do that trial because they had to do the trial in areas with high postpartum bleeding rate, because there was no point recruiting from high performing centers that have like a 0.3% transfusion rate for their standard vaginal deliveries and C-sections. Like, I put in my application to be part of the women trial, and I just got like a joke back, like, you got to be kidding, like, nobody at your hospital ever gets transfused, which of course is what we'd work towards. So it was done mostly in low and medium HDI countries where the bleeding rates are higher. In addition, a lot of those places don't have transfusion readily available. When they started the trial, that primary outcome was death or needing hysterectomy to control the bleeding, because of course, source control is just as important in obstetrical hemorrhage. But most of these people had their hysterectomy before they got their drug. So they had to change the outcome because people were getting the hysterectomy before because they have to move fast because there's no option for a blood transfusion. So if you're going to save a life, the uterus has to come out right from the get-go. So the trial was done in a very different way of practicing. Whereas here in Ontario, I always say, if the 4th unit of blood, the 6th unit of blood is going in a postpartum hemorrhage and there's no sign of hemorrhage control, we need to start thinking about the uterus coming out to save a life, along with the TXA. So it's just not as beneficial, but there's no harm and it's cheap. So you might once in a while be saving that life. And let me tell you, there's one population we don't want to lose, is somebody's mom. You know what I mean? A little baby was just born. We want them to go home with their mom.
Yeah, because correct me if I'm wrong, if I'm hearing you correctly, the number one cause of death in people under 40 is trauma. So we have a large sample of the population we can take that research from, and less so for people dying from postpartum hemorrhage. But correct me if I'm wrong too. Like the women trial had like 20,000 people in it. Like, that's a pretty large trial, and it did show benefit and no safety concerns.
Correct. Remember, in a place like Ontario, I don't know, the estimate is somewhere around of 150 women that have a major postpartum hemorrhage, only 1 will die. We're very good at managing bleeding. We're very good at managing postpartum hemorrhage. But let me tell you, we don't even want the 1 in the 150. We want it to be 0.
And that's a good point, because we have oxytocin now at our arsenal to give for the postpartum hemorrhage, like prophylactically. And we have the other maneuvers by manual compression, fundal massage if need be. That's good that we could consult a physician to get that order if it is indeed indicated.
Oh, yeah. Yeah.
What's the number needed to treat for TXA? to save a life?
So the number needed to treat that came out of the CRASH 2 trial was pretty amazing. 1 in 67.
So what does that
The
mean?
cost of, in the US, where their healthcare system is so much more expensive, it's like $500 per life saved. Like where are you going to come up with something that is so effective? I don't know. Tourniquet's probably pretty effective at saving a life. So there are probably like a few things, but when you're thinking about our average age in our trauma trials is about 20 to 30. Like you're saving an otherwise completely healthy person that could go on to live to old age. So yeah, super effective. In comparison, I think the woman trial, I'm speaking off of the top of my head, but it's much, much less. Just reaches statistical significance for death from bleeding, estimate of 0.81, but ranging from 0.65 to 1. So just reaching statistical significance. But remember, the primary outcome was death. And death only happened in 1.9% of the placebo group compared to 1.5% of the patients in the tranexamic acid group. But in their trial, that was 191 deaths versus 155. And if that's your mom, I bet you she's worth the $10.
100%. I love that we just keep saying that it's safe, effective, cheap, and it's such a versatile
It's
drug.
easy to give. You can give it fast. Easy to draw up. If you can't get an intravenous, you can give it IM. You can give it in the ambulance. I feel like, that like cat in a hat, or not cat in a hat. It was like the green eggs and ham, where they talk about, will you eat it on a train? Just like TXA, give it anywhere. It doesn't matter where you are. Give it as soon as you possibly can. It doesn't really matter where you're giving it. It's just in the first 60 minutes.
And I told you this offline, but I got asked yesterday, even though my opinion doesn't matter, they're like, if you could implement one thing for paramedics in Ontario, where would it be? I said, you're getting it already. It's TXA for all the reasons that we mentioned. So where's the future of TXA research? What are you doing, or what do you want to see done?
Yeah, I'm trying to think of anything else. I think it'd be nice to know, what is it doing to save the lives? Maybe there's some pathophysiology that, we need to better understand. Is it anti-inflammatory? Is it changing multi-organ failure? What is it doing that it's saving lives? I think we've kind of figured out in most surgical procedures, do we give it or not? Like a lot of trials have been done in different kinds of surgery. So we're very clear on, the dose trial after trial shows like 2 grams, given maybe slightly differently. Postpartum hemorrhage, it's a gram, another gram 30 minutes later if they're still bleeding. In surgery for prevention, it's a gram at entry to the operating room and a gram when you leave it. But at the end of the day, everybody's getting 2 grams. Maybe we need some more practical trials of giving it, replacing the saline flush of your intravenous with a TXA flush. Then we can cut the $10. I bet you that saline flush is like $2. So then we could make it $8. So like we could save some money on saline flushes if we were flushing with some TXA. And could you create it so it's stable? Like, could you manufacture it so we could have it pre-drawn up in a syringe so that we don't have to do that? That would be good. Maybe a bit more, science in the intramuscular so that more people feel comfortable. I think when people see really big trials, they're like a lot of people are late adopters. They don't want to be the first person to do it. But if they can see a big trial, then they're going to be like, there's trial data, I'll do it. And then maybe we'll get more people giving it IM when they can't get IV access.
What I'm hearing you saying is there's a lot of opportunities to keep researching and getting empirical evidence on TXA. especially in the pre-hospital
Yeah.
setting and in the hospital
Yeah, and
setting.
figure out the logistics. Like, not all research has to be like whatever. Like, you just have to be super cutting edge. Like just doing a large randomized trial of IM versus IV bolus, like the regular way, versus an IV push. What's the time to the TXA? Even if maybe IM isn't as fast as in its bioavailability, but you get it 20 minutes faster. So it's still faster, right? So maybe somebody needs to do some logistical trials about that. I think the other thing that you guys need to do in the pre-hospital phase and figure out is the temperature management of patients. And making sure the patients, when they come to us, they're toasty 37 degrees. Because for clotting to happen, we need a warm patient. And so we need a patient coming to us really warm. And we have some cold months of the year. And so I think we need a lot more research on what's the best blankets. You know what I mean? Like on the science. I know the lead trauma nurse at Sunnybrook is doing a trial looking at these resistive blankets that you just basically, when you open their plastic sheet, it's like those things you ski with in your hands to keep your hands warm. But it's the whole body and it keeps you warm for 12 hours. And does that keep the patients warmer throughout their entire journey? But I think we need you guys to start with the warming blankets. And can you get us warmer patients by using a different blanket? And these blankets are vacuum sealed. So they're like super thin, like it's a small little package. And can you get those on the patients? And does it change, like, does it even change the temperature when the patient gets there? People have done trials of like warming patients versus just regular blankets. And the patients rate their care is better if they were warmer. So even if it didn't change outcomes, if people felt more toasty and cozy, man, that's good enough for me. We want to make people feel good when they're coming in so they feel safe. So anyways, that's the other thing that I think you guys, like, we'll give you the summer to get the TXA in, but then we need to start talking about, getting the patients warm.
We've done a huge push on our education to talk about the lethal trauma triad, or the diamond, whatever they call it now, for hypocalcemia, because that is a huge gap. We were always taught, any trauma, cut off the clothes. Then they can't thermoregulate. They're losing heat. And then we get hot, nervous, and sweaty, especially in the summer, and we turn on the AC. So it's this ripple effect. So I agree. And I know Orange, they carry like these bear huggers, like massive blankets to help prevent hypothermia. So it would be ideal if we could get that.
Yeah. Yeah. Just, like, these aren't terribly complicated things to research. And, you have a big team. It'd be really great to see you guys do some, be pretty easy to randomize patients, to just a regular blanket or a fancy blanket, and just do anything differently.
From a hematological standpoint, what does hypothermia do for clotting?
Yeah. So, every 1 degree drop in temperature increases the blood loss by about 20% and the transfusion by 20%. 1 degree. It's so important in our elective surgery that we preheat patients before they come to the operating room, and we prevent them even dropping from 37 to 36. Even at 1 degree matters. It reduces the infection rate. They wake up in recovery room feeling better, less nauseated, less pneumonias, like less bleeding, less transfusions. And that's just like your regular patient, let alone a trauma patient. We also know that your clotting cascade is meant to function at 37 degrees, and it functions less well every drop in the temperature that you go down. The survival rate, if you drop below 34, dismal. So keeping people normothermic is really important. For Ontario, our quality metric is at the end of the resuscitation, when they get to the ICU, our target is they're always above 35. Our target is above 36. but the quality metric is they never go below 35. And so if you can bring us a 37-degree patient, that's going to help us hit the quality target of above 36 when they get to the ICU. You're just giving us a patient that hasn't lost that, that temperature.
Those are profound implications, like pneumonias, transfusions, death, like just from a temperature regulation and maintaining that.
Yes. And like basically everything you do in the pre-hospital phase has a major impact on the patient. We know that you guys going fast to the hospital improves survival. We know that if you go direct to the trauma center, the outcomes are better. If you give the TXA, the outcomes will be better. You warm the patient for us, the outcomes are going to be better. Like you play if we're going to improve and have like the best survival rates for trauma in the world, like we're going to have to figure out how to get that patient in the pre-hospital phase, getting all those things. It's hard because you got to go fast. You got to give the TXA, but I'm sure we can come up with almost like a kit. You almost need a kit. It's like the trauma pack. It's got the blanket. It's got the TXA. It's got everything that you need to just go, go, go. And so it's not going to delay getting to the hospital, but the patient still got everything that they needed in the pre-hospital phase.
You've said a lot of good business ideas during this podcast.
Right. Somebody can make some money. Yeah.
So I want to be mindful of your time. I'll leave with 2 questions. The first one is, what are the top 3 things you could tell paramedics to take away after this conversation that they can implement in their practice tomorrow that would improve outcomes?
So if you're on the fence, generally you need to give it. And I guess you always call and get back up. I'm not so sure, but I think I should give it. But remember, for our heavy periods, we give 5 days, a gram 3 times a day. So there should really be no delay. And prioritize getting the patient to the hospital, source control of bleeding before you give the TXA. We definitely don't want try to give TXA to worsen outcomes. We only want to improve outcomes. So make sure, check, got that. We're en route, give the TXA. And I guess you can always give it IM.
Amazing. And I always leave with this one question. With your dual role of a clinician and researcher, at the end, what threshold would you have to meet to say, this was a success, my work was a success?
Yeah. So, we're so used to in research of failure. And I used to see failure like you submit a grant or a paper and it gets rejected. I see it as like a challenge. I'm like, I can beat that. All I want to see is we make incremental improvements in our hemostatic management. So whether it's a trauma patient or a cardiac surgery patient or somebody having oncology surgery, every year in Ontario, patients are getting more personalized care. They're getting care that's faster, better, so that we improve their outcomes. I also, I don't know, maybe this is just to get older. I also want to improve the experience of the healthcare worker. Life's really hard in healthcare. So I think we also need to kind of focus on, one of our clients is the healthcare worker. So we need to figure out how to make it easier to do our jobs. So we want to come to work so that we're less likely to call in, I don't feel great today, I'm just going to call in sick. Because life is just too hard. I think we have to figure out how to make things easier, not harder to do. So say we add TXA to the roster of what the medic needs to do on the way to the hospital. We need to take something else away. You know what I mean? That maybe wasn't very useful to do, or we need to make it so easy that it goes along with, I don't know, it's like putting the TXA into your fluid bags. It's just running in as you come into the hospital, and it's not like you're not setting up a separate bag. where you're just always giving it IM because that's just super fast and easy. And we have like, an EpiPen throw it in the bucket. Yeah. I think, not just improving the healthcare of the patient, but improving our own experience in the jobs that we're doing. I think that those are both important and we got to work towards that.
What I hear you saying is designing things based on a human-centered focus. And I spoke about this earlier today too, that I'm reading this book about healthcare and leadership. Dr. Brian Goldman wrote it from Mount Sinai. And a Navy SEAL came in and watched healthcare workers and they're like, you guys are amazing, but you guys make your life so much harder. And we take pride on it. It's like, you're not designing the systems the best it can. And we take pride at kind of walking and crawling through the mud to get a job done. So I agree with you, but it would be nice to make things easier. And I can promise you that your work has probably saved countless and countless lives and improved outcomes. So thank you for coming on. You're welcome to come back anytime. And yeah, I can't wait to see where all this goes for TXA and trauma and every other patient demographic that would benefit from it.
So, and also just like super job well done. It's like a huge achievement to bring TXA to land ambulances. That's like, doesn't seem like much. It's a huge achievement. A lot of people to train. A lot of protocols had to be written. It's just everybody well done. It's really fantastic for Ontario patient.
Yeah, one of the best things we've ever received.